Hello again. Sharon and I would like to just kind of present for you a little bit about the Living Kidney Donor Program. And I think some of it may be a bit repetitive from what you heard this morning, but we'll quickly go over it. But mostly we want to reassure you about the process that all our living donors go through. You heard from Dr. Landsberg how important it is that we look at donor risks. And that we screen our donors. We've heard a little bit this morning about how important it is that the donors also understand their options and have their own informed choice about proceeding as volunteers in our system. So overview, we'll look at basic living donation principles. We'll look at options for the living donor, what the assessment process looks like, a little bit about the kidney paired donation program, non-directed anonymous donors, or NDADs as we sometimes refer to them, the living organ donor reimbursement program, and if we have time, we have a few case studies just to show how people actually got transplanted. So living donation principles include paramount voluntary decision and that the donor is free from any coercion. And for this reason, privacy and confidentiality must be maintained. So donor information can really only be shared by our program once a donor has been told that they're approved and that they wish to move forward. Before that, though, of course, many of the donors are very closely linked to their recipient, and they can share whatever information they want with the recipient. Or if at times the donor does ask us to share information that they're having difficulty explaining to their recipient, we can certainly do that. But up till then, we like them to have the privacy to get their information, to understand their own health concerns, and to make their own decision about whether they choose to move forward to the next step or not. So we look at careful assessment of both their short and long-term risks. And it's very important that they have adequate support systems. So although they may be very keen to go forward, they need to have a good plan for their donation and their recovery and whatever else is going on in their lives. Excuse me. They need an adequate long-term health care plan. So as Dr. Landsberg mentioned, we want them to do their annual testing. If some of the donors are coming from out of country or live in an isolated community in BC, we need to know they have access to do their annual testing and screening. And the informed consent process is an ongoing one from when our donors first contact us to when they make a decision to move forward and make a plan for their recovery. So it doesn't happen once and it's not one piece of paper, but as they become more educated about their own health testing and what it means to truly be a donor, then they'll understand whether it's the right decision for them. So their options, hopefully, would be for direct donation if they're the right blood type and the recipient doesn't have any sensitivities to them. But if not, we, from the beginning, tell them about the kidney paired exchange option. And many of our donors that have been approved and not able to directly donate have gone into the paired exchange program. In BC, it's been very successful, and about 60% of people that have gone in as linked pairs have actually received a transplant through the KPD program. For a very small number, sometimes an ABO incompatible transplant is possible. But this is a very unique situation that really is up to the transplant team to decide, and they would discuss with them if that was a possibility. Anonymous donation is when someone comes forward not linked to a particular recipient, but just feels that it's something they're compelled or want to do. And solicited donors is a reality of what is happening today. So sometimes we do know that recipients will put in an ad or do a broad appeal for a donor. And when these donors come forward, our programs do offer the donor options for donation. So they can be an anonymous donor. They can donate through the kidney paired exchange program. But as Dr. Landsberg said, sometimes people's relationships with their recipient that maybe they didn't know very well to begin with evolve over time. And we do have kind of a screening process where sometimes these donors do eventually donate for the recipient that they first came forward for. I think you saw the slide earlier from Dr. Johnson, so I won't go over it again. And as Dr. Landsberg said, we're becoming more and more comfortable with the donors in the middle-aged age range rather than the very young donors. So this just shows over time, and I think the bottom graph, which was the years got cut off, but we do see that a lot of our donors end up in the 35 to 64. There's where the majority of our donors are coming from age group. So getting started, each donor self-registers to the recipient center. So when we get a call from someone interested in being a donor, the donor program first looks to make sure that the recipient has been referred, or at least we can see and promise these days if a recipient their referral is initiated, so we know they're undergoing their early screening. And at that point, our programs will take a donor and start their registration process. But of course, we won't go too far with that until the recipient is seen and assessed. We do like to encourage multiple donors for each recipient. And so the more we have, the donor programs can triage those numbers and hopefully find the suitable or the donor that's able to move forward or the right match for the recipient. So the process for a donor, and this is all coordinated through the donor program. So it's not necessary as the KCC programs that you do any really initial screening at all. Even not really blood type anymore, because we do have the paired exchange program. We'll help the donor to get information that they need. And then once they read their information and decide that they want to be considered for the donor program, they will do a very comprehensive health questionnaire, which is their own statement of their health. And it allows us to do some early screening. So if we identify someone has a chronic health problem, or they're diabetic, or they're recovering from a recent cancer, then of course we wouldn't start the testing. But other than that, if there's no reason not to start testing, they'll do some general health screening close to home. Their family physician is consulted and asked to help with blood pressure checks and history if they feel there's any reason that they shouldn't go forward. And their family physician is copied on all their results. And we just make that as convenient for them as possible, so they can usually do the early screening, blood work, urine testing, and kind of chest x-ray, ECG close to home. They do blood type matching, so we know at that point if they can possibly be a blood type match. And we also do immunology screening, which I'll go into a little bit more later, to see that there's no sensitivities. And if they pass the baseline testing, again, at each stage, the donor gets to choose whether they want to move to the next stage of testing or not. So they'll be told that, they've passed the baseline testing. If they'd like to make an appointment for the transplant screening clinic, that happens in Vancouver at either VGH or St. Paul's. At this time, they would have a 1 or 2 day trip usually to Vancouver. They get medical and surgical review and education. They get the social work assessment, psychosocial assessment, and specific testing on their kidneys, renogram and CT scan. And as we had mentioned earlier, there is some funding for them to do that, to come for their accommodation and travel. Hopefully at that time we can make a suitability decision, but sometimes we have more screening to do or consults, depending on the complexity of the person. So the process does vary. It can be affected by either the donor or recipient's motivation, maybe their availability for testing, their health, their finances. So these things are kind of nuanced and we never really know. I think as we all keep in mind our focus of preemptive transplant, as a donor program or a transplant program, it's very important that we work on our efficiencies. But as was mentioned earlier, a donor's reason for slowing down the process or having time to contemplate whether it's the right decision for them or whether they can be available to do the next stage of testing, I don't think should ever really be pressured, or that's not where we want to see us kind of pushing to make that happen faster. And another point is that if one donor is kind of screened and found to be the most suitable donor to go forward, we still keep all the other donor files open until after a successful transplant has happened, because even at the last minute, a donor has a right to withdraw or their own personal circumstances may change. We do keep other options open for our recipients, so if it's timely for them and appropriate, they would also be considered for deceased donor transplant and for the highly sensitized program at the same time as we're working through and hoping to find a living donor. Sorry if the screen's a bit small, and this is just St. Paul's statistics, but I just wanted to give you a little bit of a flavor of what had happened over the past 2014, 2015, and even the 2015 is just kind of a 6-month period. But you can see that of all the donors that come forward, we had mailed out about 500 packages for the early registration. Of those, about 350 people returned their health questionnaires indicating that they were interested in proceeding to be assessed as a donor. After that, about the same, not too many fell out at that point. We may have screened some that I said were diabetic or had a chronic health problem, couldn't go forward. But of those, mostly they did go forward and start their baseline testing. Of that, almost half of them, though, did not go on to be seen at clinic, either through their own personal choice or because the medical screening proved that it wasn't possible for them, or sometimes because there were multiple donors and another donor came forward to clinic first. So we do try to identify the best one to come to clinic. It's a heavy use of our resources, so their motivation and our resources, we hope to get the best donor seen in clinic. Of that number, about half, again, were actually approved, and then most of those did go on to donate. And the very final number, I've seen other stats that show about 12 to 15% conversion rate from registration to actually going on for donation. So I think everyone knows about blood type compatibility, and if not able to be direct, then of course the kidney paired exchange program is available. I don't know if people really want an immunology in service again, but basically we have different levels where early on we do HLA typing for both the donor and recipient. We identify how closely the individual's genetic makeup matches, how similar or dissimilar the donor and recipient are. And there's early antibody identification for the recipient to see if the recipient has sensitivities or not. It predicts whether a kidney from a specific donor would be suitable for that particular recipient. And recipients do have a calculated panel reactive antibody screen done. It indicates the level of sensitization to the general public, and it is expressed as a percentage. And of course, we know people can be sensitized, usually through blood transfusion, pregnancy, previous transplant, or infection. These days, we pretty much do a virtual cross-match on a donor and a recipient. So once their typing's in, we just look on kind of a computer screening about whether it's likely that this kidney could go to the particular recipient. For the highly sensitized people, we would probably add in a cross-match at this point. And then with the intermediate cross-match being done, we require fresh blood specimens from both the donor and the recipient. And again, we do another screen at 2 weeks before the transplant, just to make sure that there's been no other sensitivities developed. And that's a Health Canada regulation and also a safety regulation for all transplant programs. DSA or positive cross-match means that there's a risk of rejection is too high and direct donation is not feasible. And so then other options will be looked at. And Sharon's here to tell you about some of the other options.
Thanks, Ruth. Again, some of this is obviously going to be a repeat, but I'm just going to go into a little bit further detail about some of the different options. So kidney paired donation, this is something that we've spoken about a lot. It's really a big highlight of our program here in BC, and something that we're all really very proud of here, because we've managed to accomplish a lot of transplants through the kidney paired donation program. This includes pairs where direct donation is not possible, so again, for incompatible blood types. And most often, I think what we're seeing with the paired donation is that we have A donors needing and O recipients. So there's quite a big need for O donors through the kidney paired donor program, which is important later on. And of course, immunological incompatibility, either positive cross-match or donor-specific antibodies, would mean that somebody would need to enroll in the kidney paired donation program. We normally find this information out fairly soon in the donor assessment. And it's not too often that we find it out late, so people are streamed quite early through kidney paired donation. Surprisingly, a lot of people, when we first, after sending out the initial donor screening package and the initial questionnaire, if a donor doesn't know what their blood type is, we will often, most often talk to them about kidney paired donation at that point, and most people are open to the idea. So even without confirming that they're compatible, they're still willing to proceed with the donor assessment. Through this, the kidney paired donor program, we also add anonymous donor or non-directed anonymous donors. This is a recent slide, courtesy of Canadian Blood Services, and it shows the kidney paired donor success throughout. This is the national statistics. The program started in 2009 on a national level. BC and I think it was Ontario were the first to participate, and then the other provinces joined in. We have together accomplished 429 transplants, which is a sizable number. 106 of those donors were anonymous donors, and then there were a lot of paired donors through this. Most of the transplants have come from domino exchanges, and I'll show you a picture of what a domino exchange looks like. So that's 282 domino transplants. 105 from what we call N-way exchanges, so they're sort of what we call a closed chain. And 42 from just paired exchanges. There have been 133 chains in all. We should say that of those 133 chains, I don't know how many have been proposed, but it's been a lot more than that. And so for 133 chains, there's probably been close to 300, I would say, that have been proposed, and so a large proportion of them do not go ahead for one reason or another, often because they have highly sensitized recipients who are participating in them, and we get positive cross matches, or because of the unsuitability of either a donor or recipient. This is a very simple exchange. We sort of jump for joy in some ways when we find something this simple, because they're pretty easy to accomplish. This is just a paired exchange, two pairs, typically maybe blood type incompatible pairs. And so this kind of scenario can go forward usually quite quickly. It doesn't take a lot of logistics or a lot of organization. This is a much more common scenario, and I would say this even is looking fairly simplified. This is a domino transplant, and this is where the non-directed anonymous donors are really important, and how with the addition of anonymous donors that we can accomplish a lot of transplants. So because an anonymous donor isn't tied to a particular recipient, they're sort of a free agent, I would say. And oftentimes, if they're a blood type O, they are the catalyst to starting a large chain of transplants. Our maximum in the country, I think, is 6 pairs. And the larger the chain, the more logistically difficult it is. So we're trying to, and the bigger benefit. So we are trying to, when we're doing these paired exchanges, each transplant may be at a different center across the country. One of the biggest challenges is in trying to get the different programs to look at charts. So we may be sending a donor to another program. We might be receiving a donor from another program. So even though we've looked at we've standardized the programs and standardized the assessment for donors through paired exchange, each program still needs to actually look at the donor charts and be in agreement that they feel that's a suitable donor for their recipient, et cetera. And so that takes some time. So we go from a place of having a proposed chain to looking at charts, to organizing actual cross matches, to having medical surgical reviews of the patients, and then we look at surgical dates. And surgical dates need to be either on the same day all the way across the country or within a fairly short time frame. So that presents a pretty big logistical problem on occasion. It takes a lot of work on the part of the programs, the surgeons and the hospitals to accomplish that. So the time from the match cycle, which is run by Canadian Blood Services 3 times a year. This is when all pairs are entered into the computer database. They run a match cycle 3 times a year. Compatible pairs are identified, and they will present each program with something that looks like this, not with the nice little people on it, but little a small amount of information about each individual that's proposed, and then it's up to the programs to start putting those chains together and trying to make it happen. So that happens on 3 times a year. There's a matching algorithm that's applied to the computer program, and the compatible pairs are identified. With this program, of course, travel to other Canadian centres is often necessary. And that's where LODERP and the Kidney Foundation comes in, and the social workers are a huge part of making this happen. Multiple donors, it's important to know that multiple donors can be entered for each recipient, and sometimes because of the different immunological profile or a different blood type of a donor, there can be a big benefit. So where one donor may not match in a chain, another donor may, so it just opens up the options. And I think that we're always looking at how can we just open up options for recipients, and what can we do to get that recipient to transplant? What can we look at to make that happen? The donors enrolled and recipients enrolled in kidney pair donation have to really be aware that anonymity is essential in this program. From the get-go, we tell donors and recipients that we can't tell them how many people are involved in a chain. We are asked not to share that information from Canadian Blood Services. A donor won't know who they're giving to. They won't know the gender, the age of the recipient, and vice versa. And that's really just for the protection of the donors and the programs. We don't. We're cautious about encouraging relationships between donors and recipients in this program. And I don't know if Carolyn's going into that maybe a little bit. Unmatched pairs so pairs that are not matched through the regular match cycles remain active for all subsequent runs. The timing for this and for kidney paired donor transplants is really difficult to predict. And it goes back again to the immunological profile of a recipient. Somebody who's highly sensitized is going to be more difficult to match. Somebody who's waiting for no kidney might wait longer than somebody who's waiting for blood type A kidney. Those things are, important and part of our education for donors and recipients. I will say also that through this program, we have transplanted a number of very highly transplanted people. We did a patient this year from the interior who was 100% sensitized for a second transplant and was a blood type O. So those things sort of stick out in our minds as being really good success stories. Just a brief word about the ABO incompatible transplants. Ruth alluded to. This is something, again, that's suitable for a very small number of recipients, something that we look at on our end when we've exhausted all other possibilities, and it might come into play when we have a blood type O recipient, for example, with an A donor, and the O recipient doesn't have a lot of antibody against blood type A, and there's no donor-specific antibodies. So again, it's a very small number of people. It takes a lot of resources on the part of the hospital, a blood bank, et cetera, to get these, and plasmapheresis to get these organized. And but we've done a few at each site and with good success. The non-directed anonymous donors, and again, this is important not just because anonymous donors call us out of the blue, but also because, as Ruth was saying, sometimes when we have a large number of donors who have come forward for a particular individual, some of them do elect to become anonymous donors, and it's an option that they are made aware of, or that they are often aware of before we may present it to them. And I should say, we're very cautious about how we present this information. We don't want anybody to feel pressured. But I think that by the time a lot of the donors come through to see us, they're aware that this is a possibility. Anonymous donors are sort of out there. And because they have had a good experience, they're willing to look at this. We have quite a sizable number of anonymous donors every year. We're working up more than a handful at any one time. So it's quite interesting. They're a very interesting group to work with, the altruism of some of these individuals is amazing. We do mandate that they have to be 25 years old, and for reasons that Dr. Landsberg was talking about, the risks of younger donors, when it's an anonymous donor, I think the bar is just that much higher. And they are all asked to undergo a psychological appointment or assessment as well. So that's something that we add in to the donor assessment. They're not able to influence the recipient selection, so somebody who says, I'd like to give to a child, or I'd like to give to somebody between the ages of 25 and 35, we're not able to do that. Most of them choose to donate through the kidney pair donation program, because they are aware that they could possibly influence the success of multiple transplants. And if that's not going to work for them, some of them have donated directly to the wait list. So when you're with your patients and you're seeing your patients in KCC clinics and transplant clinics, or et cetera, you may hear at some time, actually fairly commonly now, that somebody's getting either a transplant from a live donor that they're not expecting, or through the scenario with the domino chains, that somebody may be getting a kidney at the end of a chain where an anonymous donor is at the beginning and somebody off the wait list is transplanted at the end. So if you're kind of wondering how is this happening, these are the scenarios. You know, it's quite exciting for recipients, obviously, when they hear about this. Out-of-province donors, we live in a big country. We have lots of out-of-province donors, as well as we send a lot of donors from our province to other places. We work closely across the country with our colleagues. Again, the protocols are pretty standardized now. We're using a lot of the same tools now for assessment in terms of you know, tracking assessment, applying the same guidelines, et cetera. And most of the testing can be done close to home. So a donor from Saskatchewan can have most of their testing done either in Saskatoon, Regina, or et cetera. Some of the donors may travel to BC for the final assessment, and then again for donation, that might be one trip, or usually it's done over 2 trips. And for kidney paired donors, the donors are registered and worked up in their home province. So even if a recipient is here in BC and they have a sibling that lives in Ontario for paired exchange, that donor stays with that Ontario program, and we really don't have much to do with them other than connecting them through the kidney pair donation database. And that's really because the donors will probably need to travel anyway. So out-of-country donors, again, living in a big multicultural country, and this is a very common question for us at the transplant centers. You know, what about my family in the Philippines or in India, Fiji, China? We have mandated that the donors must be known to the recipients. They must be a family member. We will not consider them for paired donation just because the timing is unpredictable. They have to be ready and accessible to do testing really kind of at the drop of a hat. We ask the donors to complete a medical history and social questionnaire in their home country and some of their testing at home. And then we'll ask them to, or they will need to apply for a visitor's visa. For most countries, some of them, like Korea, for example, Vietnam, you don't need a visa, but a lot of the countries you do. This is the biggest sticking point for sure. And some of the recipients or the donors, excuse me, will have maybe out of pocket for some of the expenses for the tests that they do in their home country, but then they are not granted access into Canada. It's quite a long process to apply for a visitor's visa. The recipients also have to provide documentation about their finances, ability to support the donors, et cetera. And as we know, a lot of the recipients may not be working, so this is very, very difficult. And so I will always tell recipients, I meet with all the recipients that come through for their transplant assessment at BGH, or I do, or one of my colleagues does, and this question comes up a lot. And I will say to people, this is difficult, and you're better off really trying to find somebody within Canada first. So don't put all your hopes on an out-of-country donor. It's just not that easy. However, we do have some success with it, and one of our biggest stipulations is that the donor has to have access to long-term health care at home. The donor testing that's done in Canada is paid for through the recipient care card number, as is the surgery, and medications, I guess, like painkillers would not be covered, but a lot of most things are, most medical assessments are covered. The donor still may be found to be unsuitable, and I think that's also important that we let the recipients know that. Living organ donor reimbursement program is managed by the Kidney Foundation. Heather talked about that a little bit earlier. We provide information about that to all of the donors, also to the recipients, there's great information on the website, the Kidney Foundation website. So just quickly, advantages we've heard about through the day. From the donor perspective, advantages of donating. The donors are thoroughly screened. A lot of people love that they're getting such a thorough screening and such, really, it's hard to come by that in lots of places, so they're very pleased about that. The benefits have to outweigh the risks. There's the potential to help a loved one, friend, or stranger return to health, and most donors overwhelmingly find it to be a rewarding experience. Saying such things as nothing could deter me, or I was proud, or if I could give it my other kidney, I would. So we're lucky that we hear things like that. We're lucky to work with a group of donors. They're really amazing people to work with. And some of the drawbacks, of course, from the donor perspective, the testing is inconvenient, the recovery is kind of long, making the decision can be stressful, and I think that accounts for some of the time, the delays that plays into preemptive transplantation. Things that the donors might be grappling with are things like weighing the risks, looking at the financial impact, childcare, work, family support, and also, finding out if they're comfortable with the idea that the transplant may not work.
I think we'll have to skip.
We'll skip the case. Yeah. I've been talking too much.
Just to have a summary.
Yeah. So just we had a few case studies, but I think that some of the things we've talked about today, looking at what the different options are, they sort of were highlighting that we will look at different options for individuals, and our overall goal. So just in summary, there's more options than ever for live donor transplantation. Educate early and often about living donation. We encourage you to encourage recipients to bring family and friends to education sessions and patient appointments. Provide the donor outreach tools and sample letters. Utilize the transplant centers. Call us, let us know how we can help you. I think there's some other things that have been highlighted too about communication, and I think that we can improve on that. Remember the importance of kidney pair donation with a larger donor pool, registering multiple donors, and also we always tell recipients as well that your donor pool may be bigger than you think. So you start, and Carolyn's going to go over this, but you start thinking about who might actually donate. I kind of think that donation is a bit of a numbers game. You have lots of people step forward, and we'll do our best to find someone. Anyway, any questions about anything? Thanks.